Hey.
Good evening, everyone. Please unmute your mics because we're streaming live already. Thank you. Please mute your mics. Mute your mics. Good evening, everyone.
Good evening, Dr. Joe.
Thank you very much, Dr. Ayeni, and other colleagues on the call this evening. So we're going to be starting straight away. This is a maiden presentation of the respiratory pharmacists of Nigeria, a specialty group of the Clinical Pharmacist Association of Nigeria. And we are delighted to have men of honor joining the call tonight. Today happens to be World Asthma Day 2022. And we have a global body that contributes to asthma care all over the world. That is the Global Initiative for Asthma. So they have made celebration of the World Asthma Day statutory. And that's the tradition that we're continuing today. World Asthma Day 2022 happens to have the theme of closing gaps in asthma care. And why do we need to close the gaps in asthma care? Before I proceed, I would like one of the pharmacists on the call to give us an opening prayer. I'm going to be calling on pharmacist Mrs. Alabi. Are you with us?
Hello, good evening.
Please can you unmute and give us an opening prayer? Thank you.
Good evening, everyone. Let's pray. Father, we thank you for another opportunity to come and rub minds together. We thank you for World Asthma Day. We thank you for the great work that the health team, especially the pharmacists, have been doing. As we go into this session, we want to ask, oh God, that you come and take perfect control in the name of Jesus. Cause us, oh God, to be receivers of the blessings that you have for us this evening, and cause us to be able to impact, oh God, positively our profession and help, oh God, our clients and all our patients in the name of Jesus. Thank you, Heavenly Father, for in Jesus' mighty name we have prayed.
Amen. Thank you so much, Pharmacist Mrs. Alabi. So I was saying that the theme of this year's World Asthma Day celebration is closing the gaps in asthma care. And we need to close the gaps so that we can reduce preventable suffering, as well as the cost incurred by treating uncontrolled asthma. This goes into a lot of millions, and the suffering in this context that we are trying to make interventions for are those ones that are preventable. And other areas that we could identify as gaps in asthma care include equal access to diagnosis and treatment between care for different socioeconomic, ethnic, and age groups, between wealthy and poorer communities and countries. We also have gaps in asthma knowledge and awareness, even amongst healthcare practitioners. And that's one of the reasons we have put up the presentation for tonight, to be able to close those gaps and become updated with guidelines for treating asthma globally. So tonight, we have a presenter. We also have a moderator. I am going to introduce the moderator, and she's going to take off from there. Our moderator tonight is Dr. Foluke Ayeni, who is a lecturer in the University of Lagos. She is in the Department of Clinical Pharmacy and Biopharmacy, Faculty of Pharmacy. So tonight, I'm handing over to her, and she's going to continue from there. We're going to be having a presentation, like I said, and after that, in the course of the program, we would be having an interactive session. Of course, that will be after questions and answers. So I want you to keep keep staying on in the meeting. There are a lot of things, a lot of information that we can garner, and we will be able to garner tonight. I would also, at some point, there will be some recognitions by the moderator. At some point, our guest of honor, who happens to be the chairman, Clinical Pharmacist Association of Nigeria, Dr. Madhu, is going to breeze in and breeze out, because he has quite a lot of engagements during the same time, but he's given us the honor of joining the meeting. So when he does that, we would give him the appropriate recognition. So it's my pleasure tonight to hand over the meeting to our moderator, Dr. Foluke Ayeni. Thank you. You have the floor.
Thank you, Dr. Ojo. Good evening, everyone. You are all welcome to this maiden edition of the Respiratory Pharmacists of Nigeria's presentations. I thank Dr. Ojo for the very concise introduction she has given us. She has told us that today is World Asthma Day, which is usually celebrated every first Tuesday of May. And today happens to be the first Tuesday of May. So World Asthma Day is being celebrated today. So I think it's such a good thing that we are going to be looking at our topic today, which has to do with asthma, and also to have a time to discuss the theme that has been chosen for this year, closing the gaps in asthma care. Thank you very much. Without taking too much of our time, I want to go ahead to introduce our presenter for this evening. Our presenter this evening is pharmacist Dr. Efemuna Benjamin Uzochikwa. I'm sorry if I did not pronounce that correctly. He is a pharmacist, the chief intern pharmacist at Lagos State University Teaching Hospital. He was a multiple award winner in his days as undergraduate of the University of Benin. And he was also the chairman PAN's academic committee for the 2018-2019 academic session. He's going to be taking us this evening through the topic management of asthma. And I want us to all take our notes, be ready to ask our questions at the end of the presentation. Also, we should be ready to also contribute our beats, and we'll rub minds together like Dr. Ojo has said. And at the end of this presentation, I strongly believe that we'll come out with a better understanding of asthma, and we will be able to better manage our patients as well. So, ladies and gentlemen, men and women of honor, join me this evening to welcome our presenter, Dr. Efemuna Benjamin Uzochikwa. You have the floor. Dr. Benjamin, are you here? While we are waiting for him to respond, I will like to enjoin us to kindly keep our mics muted throughout the presentation. And at the end, we can unmute to pass across our contributions and also to ask our questions. So Dr. Benjamin, Pharmacist Benjamin, are you here?
Pharmacist Benjamin, you are muted.
Okay. Good evening, everyone. My name, according to our, my name is Pharmacist Dr. Efemuna Benjamin, and I'm representing on the management of asthma in collaboration with the celebration of World Asthma Day today. So this is my outline: introduction, epidemiology, pathophysiology, etiology, signs and symptoms, prevention, principle of management, pharmacotherapy, the mechanism of action, non-pharmacotherapy, the role of pharmacy, conclusion, then references. Then for the introduction, according to GINA, as Dr. Ojo rightly said, GINA is Global Initiative on Asthma. They defined asthma as an heterogeneous disease, which is usually characterized by chronic airway inflammation. And it is defined by history of respiratory symptoms such as wheezing, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable respiratory airway limitation. So this definition has obviously set aside from the normal cough or flu that others that patients experience. But it said the cough vary over time and intensity. They also have shortness of breath. They also have shortness of breath. Also have shortness of chest tightness, which you cannot find in the normal flu. Non-communicable disease affecting both children and adults with high morbidity and relative low mortality compared to other chronic diseases. Hypertension, that asthma, despite the fact that it's very common, that means its prevalence is very high. And with asthma, there's an high tendency of you coming down with other respiratory disease or other diseases of the body. But there's a relatively low mortality, meaning that there are lower number of people that die from asthma compared to other chronic diseases. So my introduction continues. It is the most common chronic disease among children. Asthma remains a leading cause of missed work days. We all know that the asthma, most of the time, most patients with asthma, once their exacerbation is too severe for them,
they obviously miss their work days because they are scared that if they come to work because of the stress of work, before you know, the exacerbation worsens. So it's better for them to just stay at home. They can rest and take their medications. So Gina states that asthma is underdiagnosed and therefore untreated throughout the world. It's just a straightforward fact. When something is underdiagnosed, there's no way you are going to treat it. If you don't see something, you can't take care of it. Without any problem, don't be a solution. That's just what this point is talking about. So this part, don't mind the way the thing looks like. It's just trying to classify asthma according to different types of asthma. We have not different types per se, different stages. We have the intermittent, we have mild persistent, we have the moderate persistent, we have the severe persistent. But the new GINA report kind of scrapped the mild persistent. But for now, according to the reports, there's no specific classification of asthma. So, but this classification was the last, and it's based on, symptoms and the frequency of the symptom, and also how the FEV1, which is the forced expiratory volume, and the FVC, which is the forced vital capacity, is affected. If it's severely affected, which is for the severe persistence, where we see FEV1 or PEF less than or equal to 60% predicted. So what this classification is all about is just talking about the intensity of the symptoms, because there are some people that just in a month, they don't even experience the symptoms at all. All those people, we classify them under intermittent. So let's continue. So the epidemiology, according to WHO, asthma affects 19 and causes 461,100 deaths. If you look at it, it's affecting 262 million people. 46,100 people are dying from it. According to the points I raised in the introduction, they said asthma has high morbidity but a low mortality rate. 262 million people are affected. 46,100 people are dying from it. If you compare it with other chronic diseases, you see that the prevalence of death is lower in asthma compared to other chronic diseases. In US, it is responsible for 1.5 million emergency department visits annually and up to 500,000 hospitalization, and over 3,300 Americans die usually annually from asthma. The number of persons with young people is likely to be ranked among all nature of our data collection in Nigeria. We cannot really specify the number of people that die from asthma or the number of people that visit the hospital because of exacerbations, or the number of people that even have the asthma because of our poor data collection in Nigeria, which I feel we need to improve on. That the way we give data, which is very important when we're looking towards development, will improve. There's a large geographical variation in asthma prevalence, severity, and mortality. Its prevalence is higher in high-income countries, while most asthma-related mortality occurs in low to medium-income countries. It's just a simple thing. In low to medium-income
Hello, Dr. Ifomuna.
Yes, ma'am. I can hear you.
I thought we lost you. No, go ahead, please.
Yeah, I said in low is there's high asthma-related mortality, which occurs in low to medium income to middle income countries. We know that in low to mid system is very poor income countries. You can't compare the healthcare system of United States of America to the healthcare system of, let's say, Tanzania. It's not comparable. Once the healthcare system is better, they have better outcome. compared to a low-income country where even just to get inhaler is very difficult. And also the
I think his internet is
to
fluctuating.
even purchase low to medium income country. Most of in high income health insurance scheme, which helps in the purchasing of their drugs. So no need to be removing money, even if you are still removing money you are putting into a pool that people can access. But in low income countries, everything, most of the drugs they buy is from their pocket. Whatever they make from the day they used to buy drugs. And once they don't have the money to buy that inhaler, especially when they have exacerbations where they need to buy a reliever. If they don't have money to buy and the exacerbation come, invariably the person will surely die from the asthma because there's no drug for him to use at that moment. Also, patterns in asthma incidents, the incidence of adults, but the mortality rate is higher in adults compared to children. Better boys have incidents, prevalence, and girls of the same age. That's before puberty incidents, and they visit the hospital. This curve narrows. That means both the girls and the boys, they have equal incidence. But after the age of 50, which is the 5th decade, the prevalence is more in the female compared to the male. I hope you get that. Before puberty, it's more prevalent in boys. After puberty, the curve narrows down. Then after the age of 50, it's more prevalent in females compared to males. The pathophysiology of asthma, it consists of 3 key abnormalities, which is bronchial hyperresponsiveness, airway inflammation, and intermittent airflow obstruction. So these are the 3 key things that causes the symptoms and the signs of asthma. We have bronchial hyperresponsiveness. So any activeness of the bronchioles and this airway inflammation and intermittent airflow obstruction. So once there's also, this is an image showing the pathogenesis of asthma.
Sorry.
If you look at this now from the beginning.
Dr. Efemuna, I'm sorry, I need to interrupt you.
Okay, ma.
Can you do a slideshow so that, because you did that at some point, so that you can get a better view of what you're sharing? Is that possible at your end?
Yeah, slide now, the pathophysiology.
I'm trying to.
Okay,
At some
can you
I'm there,
increase
I'm at
the
the
slide
pathophysiology.
size?
Eh?
Sorry, Dr. Joe, pharmacist
Yes.
Femina, if you can increase the slide size, it will be better. So that
I
it's
think
actually
it has to do with
Okay.
slideshow. At some point, it was bigger. You know, it became like a slideshow, and then it went back to this. So, is it possible for you to do that?
Okay.
Sorry.
While we are doing that, do we still have Dr. Madu in our midst? He came in while the meeting was on. Chairman CPAN.
Yes. Please,
Okay, can you please address
hear me?
us?
I'm with you.
Do you want to address us briefly, or you're going to stay till the end of the presentation? Hello, Dr. Efemuna, are you going
Please,
ahead?
can you hear me, please?
We can hear you, but are you able to do
audible?
something to the slide?
I'm not going, I'm single.
Okay, are you? Is it something you're able to work on the slideshow?
It's not showing.
Okay, so let's have Dr. Madu. Thank you, Dr. Madu. Briefly. Sorry, colleagues, for that interruption.
Good evening, respected. Yes, good evening, everyone. Please, I'm out. Enough.
Yes,
Hello.
yes,
Oh,
We
yes.
can hear
all
you.
right. All right. Thanks for having me. Thanks for having me. I'm on a long distance drive. I've been driving for some hours now, but I just have to park so that I can be part of this occasion. Am I still audible, please?
Yes,
Yes, you
please, we
are.
can hear you.
All right. Let me thank the moderator for giving me the opportunity to speak, and Dr. Mrs. Ojo for inviting me as a special guest to this program this evening. I want to thank all of you. I want to thank the participants because I know that if there are no participants, then there will be no meeting. And I think this is a lot of encouragement to all of us and for the desk officers of this particular specialty group of SIPAN. I can only say keep on keeping on. May the good Lord bless you. And as He's continually blessing the pharmacy profession, at the beginning of things, we didn't know that we will be getting this far, but I can see that all the specialty groups are bubbling and doing their best. And I want to congratulate you on this inaugural meeting of yours today. Please pardon me for not really preparing for this, as I've been so much occupied these days. And as you can see, I'm still on my way to my place of practice in Port Harcourt. I'm sorry, I don't know. It seems as if the network is somehow poor here too. But then let me stop at that. Let me encourage you. And let me say, I can see that the number of persons at this meeting is even commendable. At least up to 30 persons are online for this meeting this evening. This is very nice. And as we continue this way, our profession can only be better. To God be the glory for all this. Once more, kudos to all of you. Thank you very much.
Thank you, Dr. Madu.
For having me, and thanks.
Thank you so much, Dr. Madu. We're glad to have you here tonight.
Thank you very much, Dr. Madu. So can we go back to our presentation?
Yes, please.
Colleagues, please, can we kindly mute our mics?
Thanks.
Let's kindly mute our mics, please. Our presenter, can you continue? Thank you.
Can we all see the slides? This slide.
Yes, we are seeing the slides.
Is it better now?
Well, if you're not able to do a slideshow like Dr. Ojo said, you can continue. We can see it. It's just that some of us might need to strain our eyes a little, but we'll get the slides at the end of the presentation. So you can go on. Thank you.
So continue from the pathophysiology. Because we can see, for those that can see, at first, when the antigen attacks, the first thing that it attacks is the naive T lymphocytes. So for our lymphocytes, we have the beta lymphocytes, the B lymphocytes, and the T lymphocytes. For the T lymphocytes, we have the TFR cells, we have the cytotoxic cells, we have the memory cells. Then for the B lymphocytes, we have those that are the memory cells and those that produce antibodies. So for asthma, the ones that are involved are the TFR cells. That's for the T lymphocytes. So the first one that are activated are the TFR cell 0. This is naive. So once it's activated, it either goes through the TH1 response or the TH2 response. The one that is more important in asthma is the TH2 response. But the TH1 response is just the cell-mediated immunity and neutrophilic inflammation. So that one does not really have a big role to play in asthma pathogenesis. So for the TH2, which is the TFR cell 2 response, we have different interleukins and different cells that are involved. If we look through the picture, we see interleukin 4, interleukin 13, interleukin 9, interleukin 11, 3, 5, interleukin 3. The GM CSF means granulocyte macrophage colony stimulating factor. What it does, it helps for the maturation of the granulocytes. And the granulocytes that we have in our body are the neutrophils, the basophils, and the eosinophils. Before then, our white blood cells is divided into the agranulocytes and granulocytes. For the granulocyte, we have the eosinophils, neutrophils, basophils. But for the agranulocyte, that's why we have the macrophage, we have the monocytes also. So for this, what this GM-CSF does, it encourages or it processes the maturation of the granulocytes, which are the basophils. As you can see, the first thing is activating the eosinophil. Then we have the basophil, we have the mast cell, and we have the IgE, that is the immunoglobulin E. If you look at this this is the IgE, mast cell, basophils, eosinophils. They have a role to play in the pharmacotherapy of asthma, because some of the drugs, what they do is they directly attack some of these mediators. Like what they release are the histamines, prostaglandin, leukotrienes, and enzymes. For the prostaglandin that is implicated are the PGD2 and PGF2 alpha. So for now, the PGD2, there's no known analog that we have right now. According to for my own knowledge, I don't know of anyone right now. But for the PGF2 alpha, we have the latanoprost, travoprost, but all those ones are used as eye drop in the management of glaucoma. But the one that is more important is what we call carboprost. It's also a PGF2 alpha analog, and is used majorly for inducing labor. So for patients that have asthma that are in labor, it's not advisable to give them carboprost to induce labor in case they're having issues with giving birth, because that one will exacerbate the asthma that they have. But for misoprostol that is also used to induce labor, which is a PGE analog, that one does not have any role to play in the pathogenesis of asthma. So it's safe for asthma patients. So from there, the mediators of inflammation, which are the histamine, prostaglandin, leukotrienes, enzyme, they lead into bronchial hyperresponsiveness and airway obstruction. If you look at the previous slide, where I mentioned about you have the bronchial hyperresponsiveness, airway inflammation, and intermittent airflow obstruction. You see, that's what it mediates. All these mediators, that's what they do. Because about bronchial hyperresponsiveness, they lead to the blocking of the airway, and that leads to the symptoms and the signs of asthma patient experience. So the etiology, there's no single cause of asthma. That's one thing that we need to know. There's no single cause. You cannot place it on anything that, okay, this is what caused asthma. No, asthma can come at any time. It can be due to chemical hazard, long-term exposure to allergens, so, and even genetic factor. So from there, we move to the range of factors which influence asthma development are genetics, presence of other allergic conditions such as rhinitis. This genetics is very important because for children with parents, they already have asthma, and you start seeing the child start showing signs and symptoms of asthma. So what we need to do is, as medical practitioners, if we know that the parents have asthma, then we should look out for the child. So seeing signs and symptoms of asthma in that child, the best thing to do is to do a better clinical history, which just has to do with genes, and the physical examination, which is part of the key components in the diagnosis of asthma, which is clinical history and physical examination. So once that can be proven, they'll know, okay, yes, probably this child has asthma. Before we now move to the checking of the using of peak flow meter to check the peak flow rate, or spirometry to do other further tests. Also, have exposure to a range of environmental allergens, irritants, which increase the risk of asthma. We have the indoor and outdoor air pollution, house dust mites, not kite, house dust mites, molds, occupational exposure to chemicals, fumes, or dust. Okay, also events in early life that affect the development of the lungs and can increase the risk of asthma, e.g., tobacco smoking and other sorts of air pollution, as well as viral respiratory infections. So the classical signs, which usually experience at night most of the time or during exercise. Then we have also wheezing, shortness of breath, and chest tightness. So what's one thing I need to point out here is, it's not that a patient that has asthma will have these 4 symptoms. Sometimes patients will never have wheezing at all. Because most people, once they see that, okay, there's no wheezing, they say it does not have asthma. In instances where there is severe airflow obstruction, the reason is as a result of the person having difficulty in breathing. So there's a vibration there leading to the sound that we have. But once there's a severe airflow inflammation, there won't be any reason. The person will be having difficulty in breathing. And some people misdiagnose that this patient does not have asthma, and since it's not wheezing. So that's one thing I need everybody to take home, that it's not possible. It's possible rather for patients not to have wheezing and they have asthma. The prevention, which is more important for something that you don't know, that does not have a single cause, the best thing is to prevent it. Since you don't know the cause, the best measure is prevention. So the preventive measures that need to be taken is to identify and stay away from allergens or triggers. Even for patients that have already developed asthma, it's also very important for them to identify and stay away from their allergens or triggers. So let's tell them, identify your allergens and stay away from them. Because even if a patient is taking his drug regularly and is always been exposed to the allergens or the triggers, the patient will come and tell you that the drug is not working. Because every time, once the patient, it's just like you are trying to take away something, you are trying to treat something, but you're exposing the person to the same thing. Just like treating malaria, and you're still exposing the person to mosquito, which that one, before you know, the patient will tell you this drug is not working. But if you've told the patient to identify and stay away from the allergens or triggers, it's even a better measure compared to even using drug, because once you prevent it, there's no way the patient will have exacerbations. To also prevent colds, because some people, once they have cold, they start having the symptoms.
Hello, pharmacist Femina.
I'm seeing here, ma.
Okay. Are you still with us?
Yes,
yeah.
Ma.
Better view of your screen now.
Yes.
Okay, ma. So
well done.
You also, the second preventive measure to take is prevent colds. Some patients, once rain fall, before you know, they start experiencing the symptoms of asthma. So for patients that those type of things, that experience those type of situations, we always tell them that once there is rain, avoid it, or you use a duvet to cover yourself to prevent exposure. Also, it says get vaccinated rather for influenza and pneumonia. That one is very important also. Then you also take your medications as prescribed, which is very important, because patients these days, they take the drugs the way they like, not the way as prescribed. So it's good as pharmacists should always advise our patients to take the drug as prescribed, because once they do that, they get better outcomes. Also, identify and treat attack early. This is very important, because if you don't treat the attack early, the patient might die. It's just something happened today from the community pharmacy where I was. A patient ran in and was like, give me Ventolin inhaler. That is an emergency. So we had to rush. We were in Britain. So I had to tell her that those type of situations should be avoided. Always tell the person, always take your reliever with you wherever you're going to. And if it has finished, buy a new one and take it along with you, so that you don't experience that kind of situation. What if that patient goes to a place where there's no pharmacy nearby? That is how, before you know, the patient will before you know, we lose the patient. So it's experience that we always advise our patients that wherever they are going to, even if they've not experienced the symptoms for a long period of time, always go along with your inhaler wherever you are going to. Because some patients, they are very good at avoiding their allergens or their triggers, but they might be in a situation in which it's not possible for them to avoid it at that instance, and they start having attack. Because of the fact that they've not experienced their symptoms for a long period of time, they feel they are okay. Once they are exposed to it now, the attack comes, there's no reliever with them, they start struggling. So it's very important, even if the patient does come for, give me Ventolin, because that's the way patients do, give me Ventolin. Always advise the patient that, okay, Ventolin is a reliever, you must take it along with you, and it's not something that you should be taking every day because of the symptoms associated with it. Also, pay attention to increasing quick relief inhaler use. So this one is very important. Once the patient is using the inhaler, the quick relief, which is the reliever for a long period of time, is using it too frequently, you always tell the patient, pay attention to it. Once that happens, always come back to your doctor or your physician so that they will know what to do next. Okay, the principles of management. These principles of management is according to GINA 2021. Because the long-term goals of asthma are to achieve good symptom control, to minimize future risks of asthma-related mortalities and side effects of treatment. One goal regarding asthma and the treatment should be identified. This is very important. Because when we're talking with our patients, we have to tell them, okay, you have this disease. What do you want to achieve? What do you want from this drug you are taking? Because if you don't identify, to be conscious about using it. Once they tell you they go, if there's a way for you to modify it, you try and help them to modify it so they will have a better outcome. So the pharmacological options for long-term treatment of asthma fall into 3 categories. We have the controller, the reliever, and the add-on therapy for patients with severe asthma. So for the pharmacotherapy, this picture here is according to GINA. So if we can't see it clearly, you can download the GINA 2021 report and read up on it. So the first thing, once a patient comes, the first assessment you do is you confirm diagnosis of asthma, then the symptoms control and the modifiable risk factors, then comorbidities, inhaler techniques and adherence, then child and parent preference and goals. So the first one says if you go say if the symptoms occur more than twice a month or more, you see no there, I will show you no. If it does not occur like that, the only thing the patient needs to take, probably the patient is only experiencing only once a month, which is corticosteroid. Yes, the symptoms twice a month or more. You can take daily dose of ICS. Then also you can also look up on it and get the best way to treat and to control asthma. The first one was for children from 6 to 11 years, while the second one is for adolescents of 12 years and above. That means there's a stark difference between for children from 6 to 11 years and from adults 12 and above. If you check if you look down towards the low dose, the first step for 6 to is to take ICS, then whenever you take SABA with it. But for 12 years and above, the first line of treatment is as needed low dose ICS for meteor. So the former guideline was saying we should take ICS and whenever SABA is taken, whenever we take SABA, which is what they are still adapting for children 6 to 11 years. But for adults, for children, adolescents, rather 12 years plus, the first line of treatment is to give low dose ICF for meteor. So that's one thing that GINA changes is that in the 2021 report, So we can read up on the many part of it and get a better understanding. If there's any question on it, we can all rub it together and get an answer to it. So the mechanism of action of the asthma drugs, we have the beta-2 agonists, which are the albuterol, salmeterol. What they do is they relax bronchial muscles. You look out for the potential side effects, which is very important because once you give a patient a drug, you have to tell them the side effect that they are most likely going to experience. Because once they start experiencing that side effect, at least they know that, okay, this information has been passed to me before. And if they can still take it, if they manage it. But if it's a side effect that they're not comfortable with, they should tell them to go back to their physician, explain to them, and they know the drug can be changed to another one. Like for this beta-2 agonist, we have the skeletal muscle tremor, which is very common for people that use the Ventolin or salbutamol inhaler too much. You see their hands start shaking. We have tachycardia, and there's a bit of tolerance that occur, which is a question mark because this happens for some people. Before you know, when they are using only beta-2 agonist, you now start seeing the effect again. But that's why now Gina came up with a new guideline that we should use low dose ICS for meteor. So we have the other one, the corticosteroids, which have broad anti-inflammatory actions. We have the methoxantins, theophylline, which is the older ones, which comes as majorly tablets. We all know that the inhalers are far better because they move to the target site faster than the ones that are tablets. We have the Comolin or Nedocomi, which are the mast cell stabilizers. We have the leukotrienes modifiers. We have the Xifalucas, Montelukast. We have the muscarinic antagonists, ipratropium. They have the monoclonal antibodies, which is an omalizumab, which is an anti-IG, which is anti-immunoglobulin E drug. So this is the non-pharmacotherapy. If you look at it, yeah, the thing is somehow congested because the information here is very important. So there was no way I could cut it off. This is also from GINA's report. So if you need better information on it, you can go to GINA 2021 report and get more information on it. This evidence A, B, D, A means that how strong the evidence are, or the evidence is rather. We all know that cohort studies cannot be compared to cross-sectional studies. So the ones with A, cross-sectional studies have been done. The one with A, cross-sectional studies have been done, they have a stronger evidence compared to the ones with D. So if you read that you have cessation of smoking and ETS, ETS means environmental tobacco smoke exposure. We have the physical activity, avoidance of occupational exposure, avoidance of medications that make asthma worsen, healthy diets. We also have avoidance of indoor allergens, weight reduction, breathing exercises, avoidance of indoor air pollution, avoidance of outdoor allergens, dealing with emotional stress, avoidance of outdoor air pollutants or weather conditions, avoidance of foods and food chemicals. Now, the role of pharmacists, which is very important. What we should do, we should create awareness among patients. We should create awareness among patients, provide strategies to them to identify and avoid them. So we should, our first thing we need to do for our patients is we have to create awareness for them. Tell them to identify their triggers and they should avoid them. That is the first thing we need to tell our patients. Because once this trigger is avoided, the chances or the risks of exacerbation is reduced. To also screen and identify patients at risk of developing asthma or exacerbations. For patients using their reliever for too long, they are more at risk of exacerbations. Because if a patient is using the controller, as I said before, the pharmacotherapy, the options, you have the controller, the reliever, and the add-on therapy. If a patient is using a controller and a reliever together, once the patient is using the reliever more than twice in a month, it means the asthma is not controlled. While the patient is using only the reliever if he's using only the reliever and using it more than twice in a week, it means the asthma is not well controlled. So the patient needs to go and meet the doctor and explain to him. That's what I mean by screening and identifying your patient at risk of developing asthma or asthma exacerbations. We also encourage our patients to adhere to their medications through patient counseling. Like I said, some people just come, even if it's in the hospital, they just come give me so inhaler, and the doctor has written it. They don't even want to hear what you have to say, but you have to make it a point of reference that I must pass this information across to my patients to get a better outcome. We also educate patients about disease management strategies and inhaler techniques. That inhaler techniques is very important because there are some people that have sprayed the inhalers as if it's a body spray. So you need to demonstrate to the patient how to use the inhaler properly. Because if the drug does not get to the active site or to the site where it will act, there's no way you are going to get outcome. Before you know, if the patient is not using the inhaler well, they start telling you, this drug is not working, or this and that. That's why when Gina was bringing out guidelines, they also put there that inhaler technique. You need to assess your patient's inhaler technique. Once the patient comes to complain that so drug is not working, so you refer patient to specialists for further medical care. If it's something you know you can't handle or it's not in your jurisdiction, refer. There's no harm in referring the patient to a specialist on it. The patient's health is more important than the money we are going to make. Recommend an individualized treatment based upon disease severity, phenotype, and control. We know that one is not even being practiced in Nigeria. We just give a general treatment for everybody. You go and take salbutamol inhaler as a reliever. Whenever you are feeling the exacerbation, take 2 puffs. That's all. But in more developed countries, there's individualized therapy because they've already measured the PEF. They know that, okay, this is how severe the thing has been reduced. So they know the dose that the patient will need. Compared to Nigeria, we just give a general, or to low to medium income countries, we just give a general therapy for everyone. So this is very important, which is what we need to try and improve on. Individualized treatment based upon disease severity, phenotype, and control. So this for general, for the key changes that were made in interim guidelines about asthma and COVID-19. Because GINA in 2021 was done during COVID-19 came in, was more prevalent in 2020, and they did the report in 2021. So what they said is for all patients with asthma, they should be vaccinated for COVID-19. Because COVID-19 most of the time, it affects the respiratory tract. So since asthma, for patients with asthma, the respiratory tract is already affected, the patient needs to be vaccinated from COVID-19, which will worsen the respiratory tract of the person. So it's better the person is vaccinated so as to prevent the person from getting COVID-19. The treatment tract for adults and adolescents, like I said before, for trachom with low dose ICF or meteor as reliever. So now it's no more the SABA, which is short-acting beta-2 agonist, which is salbutamol. Now is low dose ICS or meteor that should be the reliever now. But from what I've seen, it's not really being practiced. We are still using the salbutamol as the reliever. So also the treatment steps for children 6 to 11, like I said before, they made a clear distinction between the treatment guideline for children from 6 to 11 and from adolescent 12 plus and above. The long-acting muscarinic antagonist. He said previous recommendations for adding tiotropium to ICS LABA have been expanded to include ICS LABA and LAMA combination, which is now a triple therapy. So now there's a triple therapy for management of asthma, and this is for patients with severe asthma. So now they now add long-acting muscarinic agent, which is the tiotropium, not ipratropium. Because ipratropium is a short-acting muscarinic antagonist. So it has now been added to form a triple therapy for management of asthma, and this is for patients that are 18 years and above. So if the patient is not 18 years, is not up to 18 years, it's not expected that the patient should be on triple therapy. So add-on azithromycin, evidence from a meta-analysis and concerns about antibiotic resistance confirm the position of add-on azithromycin for patients aged 18 and above with severe asthma. No specific evidence is available about its efficacy when added to low dose ICF LABA. So before, in the previous report, it just gave a general class that this is what we should use. You can use other erythromycin, you can use other azithromycin. But for 2021 reports, they specify that only azithromycin has a bit of efficacy, but they are saying it's still under investigation because that's why you see no specific evidence is available of what is efficacy when added to medium dose ICF LABA. So it's still under investigation. If there'll be any evidence to show that it actually help asthma patients. So the primary prevention of asthma in children, because asthma, like I said from my introduction, is more prevalent in children and the mortality rate is higher in adults. The suggestions have been added for identification and correction of vitamin D insufficiency in women with asthma who are pregnant or are planning pregnancy. So for our patients that are pregnant and they have asthma, so it's experience, you should check their vitamin D to see if it's insufficient. So if it's insufficient, they need to be given a vitamin D supplement to correct that insufficiency so that the chances of their child coming down with asthma later will be reduced. So in conclusion, asthma is an important chronic disease resulting in clinical significant morbidity, missed days of work or school, substantial cost of emergency care and hospitalization, and sometimes death. Current therapy can control asthma and may prevent development of irreversible airway changes in asthma patients. It is important to get the right fact on asthma, as misconceptions can prevent people from getting appropriate treatment. Then with proper management, people with asthma can lead an active, normal, productive, and healthy life. And these are my references. Thank you very much.
Wow. Thank you, Pharmacist Efemina, for this very educative presentation. Thank you very much. He has taken us through the prevalence of asthma. He's taken us through the pathophysiology. He has told us that it's the most common chronic disease in children. He has taken us through the prevention and the preventive measures that we can take. We've seen the principles of management. We've seen the non-pharmacological therapy that could be deployed in the management of asthma. And has also taken us through the role of pharmacists. And through it all, I believe we are better educated, or our memory has been jingled and we now have a better understanding of asthma. I suppose we can go on to take questions and answers before we move on to the other things we need to do in this meeting. So if we have any question, can we indicate by a raise of our hand? I can see a hand up. Please, let's get our questions ready so that we can ask and then we can discuss together. Pharmacist Patricia Ogbo, I can see your hand up. The floor is yours. Can we have your question, please?
Okay, good evening, everyone. Thank you, Pharmacist Benjamin, for the presentation. I would like to clarify something on prevention. You had mentioned that asthma can present at any time in life, not necessarily from childhood. If I say anything wrong, you can please correct me. But my understanding from what you said is that it can come at any time. And then when you got to prevention, you talked about identifying triggers and all other things. So if somebody has not had asthma before, how would that person identify triggers? Because most of those preventive measures that are there appear to be like those who already have asthma. But for those who don't have, how would they identify triggers for asthma? And then you also mentioned in the role of pharmacists, where they can screen for people at risk of asthma. How would you do that? I would like that clarification, please. Thank you.
Thank you, Pharmacist Ogbo. Pharmacist Efemina, would you like to respond to that, or would you like us to take all the questions and then we can have the answers together?
I think we can take all the questions.
Okay, so please, do we have any other person with a question? If there are
to
questions,
that. Okay.
you can respond. I'm not seeing any other hand up for now. So maybe you can respond to
Okay.
Pharmacist Ogbo.
Okay, thank you very much, Pharmacist Ogbo. Like I said, from the etiology, there's no single cause of asthma. So the preventive measures that are there are for those with asthma, because you cannot prevent it. So the one preventive measures are there are for those that are already developing asthma, or they already developed asthma rather, or at risk of developing asthma. But like those with, for like example, during the etiology, I think the major factor is genetics. So if the or sibling has asthma, that should be giving the person a sign that there's a possibility that the person might develop asthma later on. So the person will be avoiding the triggers. Like if the parents' triggers are this, because people's triggers are different. You cannot be saying, okay, this is the parent trigger or this. But the person needs to identify common triggers that he knows and avoid them. Because even before the person develop asthma, the person will most likely have been seeing signs. Some of them will be coming down with various allergic conditions, and they will have had allergic conditions in life before, then before you know it, will not develop into asthma. I said it in the slide there that events in previous life, those that had allergic rhinitis in previous before, they can come down with asthma later on. So for a thing that there's no cause, there's not actually a preventive measure to prevent it in per se. But for those with asthma, have developed asthma already, fine. Those are the preventive measures they need to take to reduce the incidence of the exacerbation.
Okay, thank you, Pharmacist
Thank you.
Benjamin. Okay, do we have any more questions?
I can see some questions on the chat box.
In the chat box. Okay, let me go there and just read through. A lot of commendation for you, Pharmacist Benjamin. That's very good. Pharmacist Ehikumen said, we need to do something about data collection in Nigeria for use in our presentation. I think that is in response to when Pharmacist Benjamin said we really don't have a data showing the prevalence of asthma in Nigeria, or the prevalence of morbidity or mortality. So I would want to encourage us to plan researches around that, so that we can contribute our quota to data collection regarding asthma asthma prevalence and the burden of asthma in Nigeria. Okay. A lot of commendation. Pharmacist Patricia Oduniga said, it is important to state that GINA does not recommend routine use of antibiotics in management, so as to not increase the burden of antimicrobial resistance. Okay, we can always have that at the back of our mind. We need to do all we can to decrease the burden of antimicrobial resistance.
Can I make a contribution there, Dr. Ayani?
Yes, please, please go on.
Yes. I just want to say that if we follow the presentation, we'd see that for severe asthma, there is evidence for use of azithromycin. So
yes.
you could see a prescription for azithromycin, and usually you find them being placed on it for a long-term use. You could find it as azithromycin coming on 3 times weekly for 6 months. So you don't get amazed at what is this. It is part of the guidelines, particularly for severe asthma, not the mild asthma or the intermittent, but for severe asthma, you find evidence for use of azithromycin.
Yes, I think Pharmacist Benjamin substantiated that. He got that from GINA 2021. So it's a guideline that we can go with. So we just need to familiarize ourselves with the guidelines. And when we come across prescriptions like that, like you have said, we need to get to know the disease condition of the patients for us to have an understanding of why the patient is using the antibiotic for that period of time, and then we'll be fine. Pharmacist Obianuju said, any guidelines for the management of asthma? Yes, that's Gina. The presenter mentioned it. So we can just Google Gina 2020, Gina 2021, and I'm sure Gina 2022 is in the process of being compiled. That is the global initiative for asthma. Then, can the presenter highlight differential diagnosis between asthma and COPD? Do we want to go there now or today? Because today we are talking about asthma and not COPD. But if the presenter can just give us a brief difference between asthma and COPD for a take home for this presentation, it would be much appreciated. So that's a question from Pharmacist Billy Shuaga. So Pharmacist Benjamin, would you want to give us or highlight differential diagnosis between asthma and COPD? Is this something you can do at this time? Or is this something we need to do in our future presentations? Thank you.
Okay. I could just put in a word there.
Okay.
Basically, COPD or chronic obstructive pulmonary. Okay. Pharmacist Benjamin, are you on?
Yes, ma'am.
Okay, go ahead, please.
Okay. For asthma, chronic obstruction. So the patient will be on the drug. There's no hope that, okay, the patient will be getting the obstruction will reverse or whatever. But for asthma, it's a reversible chronic obstruction. Right? For COPD, it's irreversible. So for the differential diagnosis for that, once the spirometry is done, the values you get in COPD is usually lower compared to what you get with asthma. So that's what I can say for now. We'll do further research on it.
Okay, thank you. So Dr. Ojo, do you want to add to that?
Usually for COPD also, COPD patients are usually patients that have had past history of smoking. And yes. Also usually comes in patients that are elderly as a result of degenerative disease, which comes with age. So that's one of the, but with asthma, cuts across the ages. It could be pediatric, it could be adult onset, it could be, and when the challenge is done, usually as part of diagnosis in spirometry, there'll be a salbutamol challenge. Patient they will measure the FEV1 for the patient, that's first expiratory volume, within 1 second for the patient, and then they will give salbutamol. Once there is reversal, of the obstruction, then that is evidence for asthma. Because like Dr. Efemuna said, COPD is usually irreversible. So that's one of the major distinguishing factors between asthma and COPD. Asthma can reverse spontaneously or with treatment, but COPD is usually irreversible. So patients are only managed, by placing them on medications, be able to get some relief. Thank you.
Okay, thank you, Dr. Ojo. Do we still have any more questions?
I think we can quickly move on to the next phase so that we're able to wrap up soon.
Okay, so that is talking about this year's theme, gaps in asthma care. Can the presenter please show your slides on the role of pharmacists? I think that slide summarizes where we can find most of the gaps in asthma care for us as pharmacists. If we are able to do all that he has highlighted there, in addition to some other things that we will talk about, I'm sure we'll be able to capture most of the gaps, and then we'll be able to place the patients and healthcare providers in a better place to manage asthma. So if you look at these slides, creating awareness among patients regarding the triggers of asthma and exacerbations, screening and identification of patients at risk, encouraging medication adherence through patient counseling, educating patients about the disease itself, and then the disease management strategies and inhaler techniques, referring patients to specialists for further care, and then recommending an individualized treatment based upon disease severity, phenotype, and control, even though we are yet to get there in our country as at now. So I don't know if you agree with me that we can see gaps in these roles which we can fill in our various establishments regarding our patients and the healthcare providers that we come across. Does anybody want to say anything regarding this?
Let's make it very, very interactive in the next 10 minutes.
Yes. Yes, please. So can we indicate by the raise of a hand if you want to contribute to this? While we are making up our mind, in addition to these gaps that we can identify here, I would want to say also we need to look at the gap of unequal care between different socioeconomic groups, populations, and ages. For instance, people at the high state of society and the low income earners, their purchasing power would definitely not be the same, and that can create a gap in care that they can access regarding asthma. Also, communication, maybe regarding language, regarding culture, can be a gap that we need to fill. Peradventure, a pharmacist is not able to communicate with the patient in the language that they understand. We might need to get an interpreter or learn the language to communicate with our patients in our practice setting so that we can understand each other. They can understand us better when we are educating them about the disease and other things that they need to know about asthma. We also need to create knowledge and awareness between healthcare providers. For instance, the question that came up on the use of antimicrobial, which Dr. Ojo explained why it's being used. Some pharmacists might not be aware of that. Even some medical practitioners might not be aware of that. So that gap has to be filled. Pharmacist Benjamin, your hand is up. You have the floor.
Okay. The one I want to talk about is educating patients about disease management strategies and inhaler techniques.
Okay.
So if in a community setting, for instance, I think that one is more prevalent here. A patient walks in and asks, okay, I want to buy Sevetide inhaler, I want to buy Salbutamol inhaler. It's not by just giving the patient, take, the price is 1,000, this, the price is that. You should also ask the patient, how are you using the inhaler? Who is using it? So once you educate the patient about how to use the inhaler, you are thereby bridging this gap. Because some of them don't really know how to use the inhaler. They don't know that after using it for the second time, they have to wash their mouth. And once they come down with the whitish patches on their mouth, which is oral thrush, they'll start saying, what is happening? But if you have educated the patients regarding the washing of the mouth, and if there's oral thrush, what they need to do, the patient will be scared once they start seeing all those signs there. So it's very important that when the patient comes, especially for these inhalers, you have to educate them on how to manage it, the triggers they should avoid, what they should do, what they should eat, what they should avoid, the development of asthma. Thank you.
Thank you, Pharmacist Benjamin. Pharmacist Oluyide Olabanji says pharmacists should be more involved in device techniques because most patients only receive their device without any details or demonstration on how to use it. So pharmacists will need to be up and doing regarding educating the patient on the use of the inhalers. Thank you. Any more questions or additions to this point?
Thank you, Dr. Ayeni. I would like to just add one of the ways we can bridge the gaps to adherence, for example, is to do refill reminders for our patients. You know, it's important
Okay.
that we take note of our asthma patients, you know, either in the hospital setting or in the community pharmacies, you know. So we don't just let them pass. Let's have their documentation in terms of their records. Let's take note of anybody, people that come in to purchase asthma medication, their details. You can get their telephone numbers, you know. We know that usually the medications are, a pack is usually for 30 days. So we can do refill reminders. We can send WhatsApp messages or text messages to them. Your inhaler device should be finishing. Why don't you come and get another one, particularly for controllers? Because based on GINA, patients should be on a controller medication, even if it is low dose inhaled controller, inhaled corticosteroids, okay? Then we can also do something about when we are giving out medications like NSAIDs or aspirin in our pharmacies. When anybody comes in for them, we can make it as a point of duty to always we can even have posters, you know, indicating that, you know, as a reminder to our pharmacies, you know, to say, okay, just before you dispense the NSAID or aspirin, can you ask the patient, is the patient asthmatic? Because we know the impact inordinate use of NSAIDs could play on worsening asthma. Then we could also encourage our patients, particularly those ones that are obese, to go for weight reduction, because obesity reduces, it doesn't contribute to control, you know, for asthmatic patients. And when they're able to lose weight, you know, that helps them to be able to get better controls. Then we can also recommend them to do regular exercises, okay? Asthmatic patients can do exercises because that will improve their lung capacity and decrease inflammation, you know, which we know is a chronic and underlying for asthma. You know, the only thing is if they have to do exercises, it is recommended that they take their reliever medication, the short-acting beta agonist, just before the exercise, so that they don't come up with any issue after the exercise. So then we can also recommend smoking cessation, you know, and you know, probably begin to think about setting up smoking cessation services in our pharmacies, in our community pharmacies, you know, where we can encourage, particularly either for asthma or for COPD, you know, we can help them to be able to beat the addiction to smoking, you know, and we also know that there are certain medications that can also help with this. You know, we can go ahead and, you know, stock some of this medication for smoking cessation and be able to improve, you know, that's a pharmacological lifestyle adoption in our asthma patients. I think that would just be it. Thank you.
Thank you, Dr. Ojo. Any more contribution on that? Okay. Pharmacist Olayinka Rukayat, I see your hand up. You have the floor.
Thank you very much for the presentation. I have a question for Dr. Ojo. She mentioned something about exercise being good for asthma patients, and you know, it's advisable for us to tell them to use their reliever medications, particularly before starting exercise. And I also remember Dr. Benjamin mentioning that by the time you're using the controller medications more than twice a month, then there is no control. Where do you draw the line between, you know, the use of the controller medication solely for the purpose of, you know, not having symptoms from the exercise, and the normal just using it for, I don't know if you understand my question. By the time I have to do my exercises like 2 or 3 times a week, that means I'll be using the controller medications more often than I would have if I were not exercising.
Thank you, pharmacist
Olayinka. Olayinka.
Okay,
Yes,
pharmacist Olayinka. Okay.
Yes.
I want to say that use of the SABA or the reliever medication before an exercise is prevention. So we're talking about those, the pointers of overuse has to do with those that are using it in the event of a crisis. Okay, so I wouldn't think that the times that it is used before an exercise would be part of overuse. Okay, because the exercise itself can be a trigger for some patients. So that is why there's a need. Okay, because when they exert themselves, so when asthmatic patients exert themselves, for some phenotypes of asthma, it can be exercise induced. The attack can be exercise induced. For those kind of patients, then they should. I don't think it may be across all board, but for those kind of patients that know that each time they initiate an exercise, they're going to get breathless in the course of the exercise, then they should use, their reliever medication. And in this case, it is preventive, distinguishing it from those that need to use it frequently because they are probably not on their controller medications, so they now, tend to use more of the reliever medication. I don't know if the distinction is clear.
Yes, thank you, Dr. Joe. In addition, I want to say that we should encourage moderate exercise. We don't expect, and we would not counsel our patients, our asthma patients, to go for exercises that are very hectic. So when we talk about exercise, I believe we mean moderate exercise. That will benefit them more, in addition to all the other things Dr. Joe has said. Okay. So is there a place for, I know the presenter mentioned the place for healthy diet. Can we bridge a gap in encouraging our asthmatic patients to eat healthy? What are the kinds of food that we can encourage them to eat to help them prevent triggers and then make them healthier? Can we briefly discuss this? Okay. Yes, the presenter is sharing the slide on non-pharmacotherapy. So we can pick the place of healthy diet here. Is that okay? Yes. Healthy diet encourage patients with asthma to consume a diet high in fruits and vegetables for its general health benefits. Am I right, Pharmacist Benjamin? Hello? I believe we can all see the screen. Anyway, the place of healthy diet is for us to encourage our patients.
Yes, ma'am.
Okay, it's for us to encourage our patients to consume a diet that is high in fruits and vegetables. Okay, all right, I can see another hand up. Pharmacist Oliyide, you have the floor. Pharmacist Oliyide Olabanji, you have the floor.
Good evening, everyone.
Good evening.
Yeah, my question is, how do we bridge the gap in terms of cost effectiveness? Because the complaint about from most patients is about the cost of these devices, and out, especially the preventer device, the Seritide. So how do we bridge the gap in regards to this? Yes, thank you.
Thank you, Pharmacist Oliyide. I was coming to that. That's talking about the purchasing power of the patients. So presenter, can you respond to that? How do we bridge the gap in terms of the purchasing power of our patients?
When doing my presentation, I know I mentioned in high income countries that they have a good health insurance scheme, which help patients in purchasing drugs. So the best way to bridge that gap in cost effectiveness is for Nigeria to initiate. We already have an NHIS system, but the implementation, I will say has been poor, to my own knowledge. But if they can make it better, at least this, and it should include the purchasing of the inhalers. If that is better implemented, I believe that will bridge the gap in cost effectiveness of this drug. That's my own opinion on it.
Thank you, Pharmacist Benjamin. In addition, is there a place for the use of generics? Could that lower the cost of medications to patients?
Yeah, I think that is also an intervention. Yeah. Use of generics, and I also think to take the issue of cost further, we could work on advocacies, to push and to push policies that would subsidize, probably based on the income level of patients, subsidize their treatment cost, inhaler cost.
Okay.
And then I also know at the moment there are some formulations that sort of bridge that gap. For example, I know that there are Evo-Ela formulations, as against the Discos or Acu-Ela. The Evo-Elas come across like half of the price of the Discos. I know we have for brands of a fluticasone salmeterol, we have it as a Discos as well as Evo-Ela. So for patients that cannot afford the Discos, we could recommend them to go with, the Evo-Ela. So this is something that we can do for patients to look at the pharmacoeconomic dimension while making recommendations. Like in a pharmacy, we may find a way of being able to assess our patients' purchasing power. So who to present a Discos to, and who to give an Evo-Ela to. I think that's one other way.
Okay, thank you, Dr. Ojo. That's a very good addition. So do we have any more questions or any more contributions to the presentation and to bridging the gaps in asthma care?
Sorry, I want to add something.
Okay, please go ahead.
When Dr. Ojo was talking, she mentioned aspirin and NSAIDs. So I also want to add that for patients with asthma, usually advise they should avoid the non-selective beta antagonists.
Beta 2 agonists.
Because the non-selective beta itself, beta
beta blockers,
antagonize both beta 1 and beta 2.
Okay.
Yeah, so it's advisable for them to avoid it because they act against the beta 2 agonist itself. So once you give a patient that is hypertensive, you are giving the patient something like labetalol now, in addition with salbutamol. Invariably, the patient will be getting the best outcome in both the hypertension, for the hypertensive, and for the salbutamol. Also, for patients with converting enzyme inhibitors, because they also cause dry cough, and one of the symptoms of asthma is dry cough. So for patients with asthma, we should be cautious with them when you're giving them ACEIs, because the dry cough that they cause might worsen the symptom of asthma itself. So that's what I want to just add.
Okay, thank you, Pharmacist Benjamin. I don't know if we still have any more questions or any more contributions. Okay, so thank you once again, Pharmacist Benjamin, for the very educative presentation. We have had a review of asthma this evening. We've seen or heard that it's a disease of high prevalence, high morbidity, but thankfully low morbidity. We've seen the pathophysiology of it. We've seen the medications that are used in the management of asthma, the triple therapy, the inhaled corticosteroids, the LABA, the LAMA, and the add-on therapy. We've looked at the non-pharmacological therapy that we could deploy in the management of asthma. And we have looked at the principles of management itself. We've seen the role of pharmacists. And I'm sure every one of us this evening, we are 1 or 2 steps wiser in asthma care. And the next time we come across our asthmatic patients, we'll be better equipped to counsel them, to help them to adhere to their medications, and then to also recognize their symptoms, the ones that are mild, that are severe, when they need to seek care, and when they need to go back to the healthcare provider when their symptoms are increasing. So I want to thank everyone for listening to this presentation. And I want to hand over back to Dr. Ojo, our chairperson of the Clinical Pharmacists Respiratory Group, for what is left of this meeting. Dr. Joe, over to you.
Thank you very much, Dr. Ayeni, for the robust moderation you have given to this program this evening. We appreciate you. And thank you so much to the presenter of the day. I'm wondering if Pharmacist Ajayi is still on the call. He's supposed to give a vote of thanks for us. Pharmacist Ajayi of Shekinah Specialties, are you still on with us? Okay, it appears he dropped off. Okay, so we want to thank everyone. We appreciate you. This is our maiden presentation, and we look forward to having more presentations. As men of honor, we look forward to you joining hands so that we can push, you know, the respiratory pharmacy agenda and be able to make the impact that would improve the quality of life for our patients across the various levels of care, both within the hospital, in the community settings, and everywhere that we can add a voice to the management of asthma. We thank you so much. World Asthma Day 2022 would remember you, and it is noted in history that you participated and you joined hands to make it the success that it has been. So we appreciate you so much. And please join our the Respiratory Pharmacists Association if you're interested in developing this specialty. And we also encourage you to join the Clinical Pharmacists Association of Nigeria, which is our parent technical group, I would say, under the Pharmaceutical Society of Nigeria and under the AHAPNI, Association of Hospital and Administrative Pharmacists of Nigeria. So we would like you to be part and be able to garner a lot of things that would improve our practice and help us to stay abreast of global best practices. So thank you so much. And we look forward to having you on whenever we do call for a meeting. I would like pharmacist Olorun Shola to please give us a closing prayer. Or Dr. Ayeni, do you have somebody to give us a closing prayer?
If Pharmacist Olani Shola is here, that's fine. But if he's not here, I would like to call on Dr. Ogbo to give us the closing prayer.
Over to you, madam.
Let's pray. Father, we give you thanks for helping us through this presentation this evening. We acknowledge you. We thank you for the way that we have added knowledge today in different ways. We thank you for the presenter, the moderator, the chairman, and for everyone who attended today. We ask, Lord, that we will keep growing in knowledge in these areas, and so that we can be helpful and be blessings to the patients that we come across. We ask, Lord, that for future presentations, that you will show us the way to go. You will show us the topics that are relevant at the time, and that we will present it to the blessing of man and to the glory of your name. In Jesus' name, amen.
Amen. Amen.
I can see somebody on the call, Dr. Ayeni. I can see Dr. Adeshino, who is the vice chairman of West African Postgraduate College of Nigerian chapter and the chairperson of HAPS. Thank you, Dr. Adeshino, for being on the call. We appreciate you.
Thank you, Dr. Adeshino. Thank you for coming.
Good evening, Dr. Joe. Good evening, everyone. Thank you very much.
Good evening, ma'am. Yes, ma'am.
I can also see Pharmacist Ajibola Tajudeen. I don't know if he's an officer of PSN or APNI.
APNI.
Okay. That's our, can you please introduce yourself, and we appreciate you for being on the call.
Yes, I'm with the primary care board. Lagos State.
Okay, thank you for coming.
You're welcome.
I'm past secretary at APIN Lagos chapter.
Okay.
Let us know that.
Okay, yeah, that's what I knew, that he has an office, he's occupying. So that's the secretary of AHAPNI Lagos chapter, Pharmacist Ajibola. We appreciate you. Thank you for being
coming.
On the call.
Thank you for coming. Okay.
Okay, I can see my people from Lasut. A lot of my colleagues are there. Thank you for joining the meeting to encourage our presenter of today, Dr. Efemuna. I can see directors of pharmacy, pharmacist Odunuga, Dr. Odunuga. I can see pharmacist Davis. We appreciate you. I can see pharmacist Alade Shawe. I can see pharmacist Alabi was on the call earlier. I can see pharmacist Oliyide.
Wow, thank you all for coming.
Yeah.
Thank you for being on the call.
Yeah. So, Dr. Ayeni, last call from you. Over to you.
Okay. I want to thank everybody once again for being on the call this evening. I want to thank everyone we have called on to do one thing or the other, and that you have heeded our call. For all our officers of CPAN, AHAPNI, and the officers of LASU, lecturers from the University of Lagos, thank you all for coming. You have all made the maiden edition of our presentation a very memorable one. I trust that the next one we will even have more people. Let's publicize this group to our various colleagues, and let those that are interested in respiratory diseases also join this group so that we can rub heads together to better the care of our patients with respiratory issues. Thank you, Dr. Ojo, for the robust contributions also you have given us this evening. Thank you to the presenter for presenting a well laid out presentation on asthma. I thank you all, and I pray that we will all have a good night's sleep as we hit our beds this evening. Thank you, and God bless you.
Okay, good night, everyone. You can unmute and say good night and goodbye. God bless you.
Good night.
Yeah.
Good night.
Good night and God bless.
Bye.
Good night. Bye.
Sorry, the slides. Presenter, can you share the slides to Dr. Ojo so she can pass it across to us, please?
Yes, you will do that.
All right. Thank you very much. Good night.